Final review, lecture 2. We continue with market analysis of the United States healthcare system. Let's start with the private health insurance industry. So we have large number of the health insurance companies in the national level, so reasonably they're competitive in the national level, but they're highly concentrated in most geographical markets. The barriers to entry are low. The products are reasonably homogeneous, means that they have the same almost insurance coverage in most of the cases. The consumers' information in the group buyers market is relatively complete, but there are also some information, imperfect information in some cases, for that you don't know exactly what type of coverage you have when you need that insurance. Then in terms of conduct, there are some undesirable practices with respect to the benefit denial, cherry picking, and high premium charged to the medically, basically sick people with multiple chronic diseases. They have to, or older people or women, they have to basically pay more than men. The performance basically determined by the number of the outcomes. The outcomes are by number of the people are insured. As you know, there are a large percentage of the people in the United States are uninsured, about 9% after the Affordable Care Act, which still is the highest number of the uninsured among the high income countries. As you know, a family without health insurance coverage faces substantial financial insecurity. So that actually is another performance of this industry. We can actually name it. So the question would be here, what is the principal catalyst for provision of government intervention in the market for health insurance? Is that uncertainty, population growth, disease prevalence, imperfect information, or health expenditure growth? Which one is that? Yes, it is. Imperfect information is the main reason for government intervention. So especially, basically, we are talking about imperfect information for patients compared to the providers. The other question would be, what is the average, when the average total cost of providing insurance coverage decreases as the firm provides coverage for larger groups of people? So basically, is this called moral hazard, asymmetric information, rationality, scale economies, or adverse selection? It is basically scale economies. And the next question is, which of the following reasons might explain why health insurance purchased as a group might be less costly than coverage purchased individually? Is that because of the greater bargaining power, risk spreading over a larger number of the people, lower marketing costs for providers, A and B, or all of the above? The answer would be all of the above. Now, the next actually industry in the United States healthcare system would be physician services industry. As you know, the number of the physicians per capita have been grown substantially over the past few years, but so we have barriers to entry into this medical practice. Of course, the physicians, they have to study so many years of basically in the school to get the medical licenses, so it's not easy to get into the medical school. It's not easy to finish that and practice. So there is a huge barriers to entry. From the structural issues, there are too many specialists, but not enough primary care givers in the United States. And the other point regarding the structural issues is the government and managed care organizations. The bargaining powers to extract the price concessions from the physicians, basically dictating what the physicians and, of course, the patients they have to do. There is an asymmetry of information between patients and physicians. Physicians they have better information about the right type of treatment for patients. The practice there is a practice variation across the geographic regions, and there is a growth in physicians' prices and expenditures, which basically outpace the growth in the general price level and the overall economy. The next industry would be hospital services industry, which definitely there are substantial barriers to entry with respect to the certificate of need laws, huge sunk cost of the building, hospital and learning curve effects. Most hospitals they have standardized products, so they have homogeneous product, but the large teaching hospitals they have better quality. So we have to consider that. So there are not completely homogeneous product. The patients, consumers, basically both their kind of basically patients or which are the consumers in the hospital industry, they're relatively uninformed. They don't know exactly what are the appropriate treatment for them. There is a little incentive to comparison shop for hospital services because the majority of the costs for hospital are paid by insurance. Out-of-pocket price for hospital services is 3 cents on the dollar. So therefore there is a huge moral hazards problem in this hospital case in the United States. The institutional buyer, MCOs and governments are basically have the greater buyer roles. And with respect to the performance, hospital expenditure accounts for 5% of the GDP, and the hospital price inflation rate is greater than the general price inflation rate, and that's actually basically is related to the staffing ratio increase in the wage rate. And that's because of so many factors we talked, because of the higher training and number of the years the staff in medical care, nurses and physicians, they have to go to the school, which basically have been increased over the past few years. The hospital price inflation rate. So the question would be, which of the following reasons might serve as a barriers to entry within the hospital services industry? Is that scale economies, standardized product, certificate of need, both A and C, and all of the above? The answer would be scale economies and certificate of need. The last industry would be to basically analyze is the pharmaceutical industry. There are ample signs of price competition in the pharmaceutical industry during the patent periods. Branded drugs compete against other branded drugs. Specifically, they compete with the drugs that are treating the same illnesses, basically, but with different, of course, chemical compositions. After the legal patent period expired, then the brand drugs competitions from generic drugs, and then the generic drugs compete basically among themselves. There are high promotion expenditures for basically advertising. These there are two basically ways to looking at it. One is informative, and the other side is a persuasive role of these advertisement. The product competitions are in terms of research and development expenditure, depends on the cash flows, and the real drug prices have risen over the past few decades, but there is a gap between the drug price inflation rate and general price inflation. This gap has been narrowed in the recent years. The pharmaceutical profit rates are much greater than the manufacturing industry average. And remember that increasing the price of the price should be considered as a higher quality of the drug, which basically decrease the number of the hospitalization. You have to consider how it's affecting the whole basically healthcare costs. Now, recently you heard that the CVS buys health insurance Aetna for $69 billion. The question would be, what type of merger is this? Is that vertical or horizontal integration? Is that bad or good for patients? How the merger impact drug prices and patient outcomes? So you need actually to go to these websites and see the answer in more detail. But briefly, a CVS deal would be so-called basically vertical integration and basically an acquisition along the company's supply chain rather than a horizontal acquisition of the direct competitors. So this basically vertical integration usually are considered less threatening to antitrust authorities than the horizontal integration. Now, how is it affecting the patient's outcomes and drug prices? First of all, this transaction fills an unmet needs in the current healthcare system and present a unique opportunity to redefine the access to high quality care in lower costs in the local setting, because basically the CVS is kind of a drugstore in every corner in your community. So therefore, what happened? Buying Aetna will make the CVS even more of an insurance company instead of a retail pharmacy. For example, they might be able to basically Aetna might be able to negotiate the lower drug prices from manufacturers by virtue of their sheer size. And so basically this may increase the opportunity of decreasing the price of the drugs and, for example, even increasing the patient's outcomes. For example, an integrated insurance could provide pharmacy benefits to incentivize you to do things like filling your blood pressure pills so that you don't end up in the hospital. So that may actually improve patients' outcomes. Now the question would be, product differentiation may stem from which of the following: location, quality, advertising, all of the above, none of the above. So the answer would be all of the above. So in terms of the overall healthcare economy, the prices and expenditure on various medical services continue to rise at a slower rate. Now the transition to managed care healthcare system, yes, there are some cost saving in various medical care markets. The movement to a managed care healthcare system is limited to the choice of physicians' autonomy and income, and hospital inpatient admissions, and selection among the pharmaceutical products. So this is the end of lecture 2.